Thank you, Larry. Again, we will be having a panel with both of our speakers after the break. But right now, let me introduce Paul Menzel. Paul is professor of philosophy at Pacific Lutheran University, where he has taught philosophy and bioethics since 1971. He has published 2 books on moral questions about healthcare economics and numerous papers about access and rights to healthcare. He is co-editor of a forthcoming volume of original papers, Prevention versus Treatment, What's the Right Balance? So Paul, welcome to Seattle.
Thank you very much, Ben, and thank you all for being here. I'm a teacher, and I tend to run through material viciously, some of my students say, mercilessly. So this is fairly packed, and it's only about halfway through that I get to children. So I beg your patience in the meantime. And John Lantos has already used up my quota of humor that I'm capable of, so I'll beg your forgiveness for not throwing a lot of that in either. My central claim is that generally, not just for children, already in the United States, we have not just a natural, ideal moral right to health care, that though we don't have a legal right of universal access for everyone, we already have what I call an existing realistic moral right, or what you might call a cultural moral right, rooted in existing facts that people of a wide variety of persuasions, conservatives and liberals alike, acknowledge, agree on, and rooted in values that they all alike share. So that when a person makes a claim to universal access to basic care in our society, they're making a moral claim to the society and to others that is for those people to whom they make it on the basis of shared values. This is a pretty ambitious claim, but I'll try to flesh out the argument. It includes these facts, market failure of insurance, and then the fact of obligatory rescue care, emergency care that represented in EMTALA, and 2 values, the unfairness of free riding and just sharing of the costs of illness. Though children age 1 to 14, I'll confine it to them for this claim, are the healthiest segment of the population, they have an equally strong, but not stronger, right to basic health care. The first argument strategy focuses on market failure of insurance. And this should appeal especially to free market conservatives. And it involves very few value assumptions at all. It's an observation about how markets work. Economists have made this, many economists have made this argument for a long time. Competitive markets for voluntary private health insurance segment quickly into high-risk and low-risk pools. Why is that? People buying insurance, and notice the market here that we're talking about is a market for insurance, not a market for care. That's a little bit different. The market for insurance segments into high-risk and low-risk pools because the buyers who are healthiest want lower premiums. And the sellers won't insure the most likely ill except for very high rates, which then the likely ill don't want to pay or aren't able to pay. You just leave buyers and sellers to compete in an open market, and that's what's going to happen absolutely predictably with the good called health insurance. Noted as the classic case of such behavior in the market by Kenneth Arrow back about 60 years ago, a famous paper. The likely ill then get priced out of the market. Yet they are the people who most need insurance. That's what the good is most important for. A market for a good that fails to deliver the good to those who most need it constitutes what economists call a failed market. 3 remedies for market failure. 1, you can say everybody needs to belong to one common pool, so you can't segment. Now, that's not going to have multiple insurance companies. That's going to put everybody in one insurance company. And objectors to the defenders of market strategies say it doesn't preserve a market for insurance. It erases the market for insurance. But you can also, within markets for insurance, bar insurers from charging widely different premiums by likelihood of illness. That is, you can require community rating. But then the healthiest bow out of insurance because they don't get the bargain premiums anymore. They get an intermediate premium, and a lot of them bow out. And we see this in states that have adopted community rating. The rate of uninsurance goes up very predictably. People are just being rational. Premiums for the remaining, if more of the healthy people bow out, go up more yet, and it's the vicious cycle, and it's called the death spiral of insurance. The eventual solution to this is to mandate that everybody have insurance within a moderate range of community-rated premiums. There's a third way that you could address this, and that's by very hefty subsidies for high-risk pools. Let the market segment itself. Yes, it costs $50,000 a year to get insured if you're of a certain high likelihood of expensive illness, expensive to treat illness, but then we'll just supplement we'll put you in a high-risk pool and give you a $40,000 subsidy so your annual premium is the same $10,000 as other people. Now, if you were to do that, which Republicans have proposed doing for the last 8 years, it wouldn't take just the $5 billion or $10 billion that they've put on the table for that. It will take $100 billion, probably, which is the net cost, notice, of PPACA to bring all the people into an additional insurance in the health reform plan of 2010. It's no bargain. That strategy is no bargain. The second argument, that's the market failure argument. And I don't think there are a lot of values involved in this argument. It's just an observation that the good of health insurance is most important to people who are likely ill. How do we get it to them? These are the ways to get it to them. The second argument strategy is more complicated, but I think it actually represents more what our society is thinking in terms of the moral issue of universal access. The summary of it is this. You start with EMTALA, obligations to rescue, imposed on providers. Note that costs are shifted largely to those who insure, other payers to hospitals, some who do not insure free ride. If you think that's not true, just ask a group of 24-year-olds who are just a couple years out of college, don't have insurance from their parents anymore, don't have insurance through the school, and they're going bare. Quite a number of them go bare. But they have accidents too, and they end up in ERs. And they don't have any assets, at least unless their parents aren't connected with them enough to tap, and they're, after all, over 21, and it's difficult to tap their parents anyhow for hospitals. Solution? Mandate insurance. To be affordable, premiums, however, must be community rated, because if you mandate insurance in an unfettered market, you're mandating that some people spend $50,000 a year for insurance. And some will have to have subsidized, even if they're not the more likely ill. Common premiums constitute a just sharing of costs between well and ill. This is the larger argument. Step one in this argument, emergency care. This, thanks to Doug Deacon, I don't need to say much more about. But I will argue that the cost shifting is significant here. I know that there are estimates by economists that vary a lot, run basically between $500 and $1,000 a year per family of four's premium. That is, people who do buy insurance pay an extra $1,000 or an extra $500. There's an argument about where in that range it falls for their insurance because of cost-shifted care to those who don't have insurance, much of which is emergency rooms. Or note the care that's complementary to emergency rooms that hospitals give because they don't want the revolving door, the same patients coming back in a month. They give a lot of technically non-emergency care. ER patients get transferred into a regular room in the hospital because the hospital's smart enough to know that they're stabbing themselves in the foot if they kick them out the door without technically non-emergency care. They'll be back in a month if they don't get 3 days of other care, whatever. So that amount of care is quite considerable. Step two, Inefficiency. The use of ER care as a substitute for primary care is costly in money and in health. I don't need to give you evidence of that. You all know that for good reasons. This makes the burden of involuntary cost shifting all the more objectionable. It makes it galling because those who pay more for their insurance because of the cost shift are really paying for very inefficient care. Now, I don't mind having to pay without having chosen to pay for care for those who can't afford it that's efficient care. But I certainly do object to paying for wasteful care, care that could produce more benefits at a cheaper cost in another way, which means the only way to get rid of this inefficiency is to cover primary care within basic care. No other way around it. Some who are in situations economically similar to the situations of people who insure do not insure. They get the benefits of emergency care without paying. I've already noted that. So the solution to both inefficiency and free riding is to require broader insurance for at least primary care. Require it, mandate it. It's the only solution. Step 3. For mandated insurance to be fair, it must be affordable. To make insurance affordable to the likely ill, regulate insurance, ban pre-existing condition exclusions, and most experience rating. There is the option of establishing these very expensive high-risk pools, costing about the same amount, or maybe even more. To make insurance affordable for the economically disadvantaged, one will also have to provide graduated subsidies for insurance. So you have to restrict the ability of insurers to use pre-existing condition exclusions, to have segmented premiums, much higher premiums for the likely ill, lower premiums for the likely well, and you have to provide some other graduated subsidies to make the mandate fair, because it has to be affordable. That is affordable to the people who are required to be insured. Next stage of the argument. Barring insurers from pre-existing condition exclusions, premiums that vary widely by risk of illness and other market segmenting devices is justified not only to avoid market failure, it's also justified to achieve a more just sharing of the expense of illness. There is a moral value at stake here. It's the principle of just sharing. Financial burdens of medical misfortune ought to be shared by well and ill alike unless the ill created the burdens by their own choices. Now, this is likely to be observed. It's likely to be observed that this is particularly controversial. Why am I claiming this is a shared, widely shared value in American society? I'm very convinced that it is. To explain that, I need to move to a wider principle, a wider discussion of principles of just distribution. Convictions about equality vary. On the one extreme, libertarian ones. We're not obligated to help someone in misfortune we've not caused, in their misfortune that we have not caused. On the other egalitarian extreme, equal resources for all. If I have more, regardless of what's the cause of other people having less, I must help them. The vast middle ground in American moral culture is occupied by something that some philosophers have called, you wouldn't have to call it this is a common term for it in philosophical circles, equal opportunity for welfare. It is unjust for individuals to be worse off than others due to outcomes it would be unreasonable to expect them or have expected them to avoid. Great book by Shlomo Siegel a year ago from Princeton Press entitled Health, Luck, and Justice, about this larger view. Equal opportunity for welfare implies the principle of just sharing in regard to one particular facet of life, financial burdens of illness. How widely shared are the values that generate this larger argument? EMTALA, very few advocate repeal. Headline threats to hospitals if they don't before, even in 1985, before 1985, that they were dumping. You have to have some cultural objection to not rescuing when people really need to be rescued in order for headlines to be a threat to the hospital. If EMTALA were repealed today, those threats would still lead many hospitals to do the same thing they're required to do under EMTALA. But most importantly, there was no proposal whatsoever to repeal EMTALA in all the vigorous debate of 2009 and 2010 that continues to go on about the Health Reform Act of 2010. Not one conservative publicly, out in the political world, a few odd ones in the blogs, but that's all, said we got to get rid of EMTALA. So EMTALA remains as an uncontested linchpin of this argument. Now, free riding, countering free riding, that is not letting free riders get away free, is central in conservative philosophies because of public goods arguments. The conservatives' minimal state is, in fact, one run by the we must avoid free riding. I get a good from education, other people being educated, whether I want to get that good or not. It buoys the society from which I get benefits of welfare left, right, and center. And these public goods require everyone to contribute. And it's not public goods are not the only context in which the avoid free riding, reduce free riding, counter it by required contribution arguments work, but it is one of the major ones. And it's very dear to conservative political philosophies. It's the central principle dear to them. Finally, just sharing between well and ill, conservative support for banning pre-existing condition exclusions, for example, and for high-risk subsidy pools, has been wide across the political spectrum. That's not what Republicans and conservatives are disputing in PPACA. Moreover, this argument is widely applicable to different systems. These values require universal insurance for basic care. They do not dictate the form of the system that delivers that care. The system can take the form of either single-payer insurance. You have to add a few other assumptions about efficiency, reducing administrative costs, et cetera, to get there. But you could get the single-payer insurance. But if you don't have those assumptions or don't agree on them, what you do get to is mandatory insurance in a multi-payer system, which, by the way, is what Germany has, as John Lantos mentioned. Germany, Netherlands, Switzerland have, and run apparently both very effective, very cost-worthy, and very fair systems. Now, admittedly, they regulate the insurance market much more highly than we do, much more highly than even under the Reform Act of 2010. But I think here there's a very widely shared set of values from which it is clear people do have a right, a moral right of, an actionable moral right, if you want to call it, that is a right on the basis of which people can make their moral appeals that they must have universal access to basic care with a straight face to society and not in an ideological contesting one in which we have people who don't share values. Insurance for children. All of the values used in the argument above apply to insurance for children. Rescue and emergency care. Suppose you were to leave children out. Well, we care more about not having adults die at hospital doorsteps because when they don't have ability to pay. You just left children out of EMTALA. No. If there's any motivation in the society behind this appeal to rescue, identifiable people's lives and health, immediate health, are at stake. Let's call that the rescue principle. The appeal of the rescue principle is certainly not less for children than it is for adults. Furthermore, primary care in relation to emergency room visits is especially effective and efficient for children. It's also true that especially effective and reasonably cost-worthy for children is preventive care. So the link from EMTALA through this inefficiency observation to universal access to primary care is at least as strong in the case of children. Now, children themselves aren't free riders, but their parents certainly can be. They'll say, some parents undoubtedly have said, well, my kid will get free emergency care anyhow. Now, this happens much less often for a series because of a number of social dynamics than it does with, you don't have the quintessential parent here parallel to the quintessential 24-year-old whom I described before, who can free ride because they're assured of getting emergency care if they have an auto accident. Whatever. But nonetheless, theoretically at least, the principle applies. Just sharing certainly applies to parents' expenses for their children. Should we have any less sympathy because of equal opportunity for welfare, fundamental conviction about distributive justice, should we have any less sympathy for parents who get burdened with great expenses for their children's much greater than average illnesses? The just sharing of burdens that are not brought on by our own lamentable, fault-worthy behavior, blameworthy behavior, is certainly applicable to the parents' expense for children's care, as applicable as it is for people's own expense for their adult care. Now, is the right stronger for children, or is it wider in its scope? Children are typically more dependent on others for access and for actual care. Children can't fairly be made responsible for their own insurance. Yes. In that sense, the mandate for insurance for children is an easier argument than the mandate for adult insurance. And it's interesting to note that we might have taken that route if we had been less exercised by the injustices and unfairness of lack of universal access to primary care and other care for the population generally, not just for children. Obama, in the 2008 campaign, in fact, did not support a mandate. He did not support single payer in that campaign. He did not support a mandate, except for children. That there must be a mandate for children's health care insurance. It could have been the first step because the argument is easier to make in the case of children. But then there's this other point. Children have more life opportunity, it will be said, at stake in healthcare than adults do. I don't think that one can make that argument. At first I thought you could by simply the number of years. And after all, if you imagine a child is dying at 10, compare their loss of opportunity to an adult dying at 30. Isn't there a lot more opportunity, namely the opportunity to have gone through the teenage and college years, early adult years, for the 10-year-old than there is opportunity lost for the 30-year-old? The reason I don't think that's correct anymore is opportunity is a very subjective, slippery thing. We look at opportunity not just in smaller slices. When we're 30, the opportunity that we have was not even in view when we were 10. I now have the opportunity to see my 3-year-old go to kindergarten in 2 years, to have the second child that my partner and I want, etc. I mean, they're just different opportunities. Are they any less valuable? Are they any less vivid to the 30-year-old than the opportunities to a 10-year-old are, or than the opportunities to a 10-year-old are for her parents? I don't think so. Now, if we push it out to 50, 60, maybe there's less opportunity at stake there. But even there, I'm not quite so sure. Take the example of my late wife who died at 65 when her oldest grandchild was 7. And one of her 5 grandchildren was not yet born, and the youngest one was 6 months. She felt, relative to her desire to be a grandmother, that she didn't have much of an opportunity to be a grandmother at all, because it was missing all that stuff in the middle years of the child, which was among the most important grandparenting role that she had had in her childhood. Now, well, yes, she lost less opportunity than a person at 30 who dies, I suppose. But boy, that was a major opportunity that she lost. And she viewed her own life as missing a huge identity-defining opportunity. I don't want to make the argument for equality here. I just want to note equal opportunity no matter when you lose life. I don't want to make that argument at all. But what I do want to make, the argument I do want to make, is you can't just draw the line at 18. You cannot draw the line at 18. And therefore, the claim that children always have more life opportunity at stake in healthcare than adults do is not true. Here's Callahan's question in the reprint that went into the packet. Sometimes 10-year-old articles are still very, very good. And I wasn't aware of how good this one was until I went back and reread a number of things. Just thought, this is the one I'm going to pick to put in the packet. And there are a lot of things in that article I commend to you, but one of them is that he takes up the challenge. Children are the healthiest, under 14 and under are the healthiest segment of the population. Sorry, 1 to 14, not under 1. Let's confine this to eliminate the infants. From 1 to 14, you have the healthiest segment of the population. That is, if you didn't have any health care whatsoever for that group of the population, it'd still be pretty healthy at 15. More healthy than any other 15-year segment of the population would be at the end of that segment. Well, that's true. But still, in the long term, primary and preventive care for children is both relatively effective and it's relatively inexpensive. And if we're therefore going to require people to buy insurance, wouldn't we want the most relatively effective and most relatively inexpensive care to be in there first? And children are a prime example, children for primary care at least. Absolutely clear, strongest example you can get. Now, if this last point is persuasive, and it's not Callahan's only point, and it wouldn't necessarily be my only way of responding to this challenge, but children are the healthiest. Note the implications for prioritizing care in general. I think there are implications. The implications are that effectiveness and expense can be used to set limits, to get people in as especially important and sensible, or not to keep people in at the limits of care, not to keep particular procedures in at the limits of care, for adults too. I don't see how you can make this argument about effectiveness and low expense and the importance of prevention for children if you don't also acknowledge that depending on the particular numbers about expense and effectiveness and the power of prevention, et cetera, I don't see how you can keep it out of the adult population. And in relation to prevention treatment, which is, from Ben's introduction, I have a particular interest in this last couple of years, in compiling a book with Hallie Faust, a wonderful preventive medicine doc from Santa Fe. Our society thinks, and there's lots of evidence for this in the way it behaves, that treatment is more morally important than prevention. The fundamental reason is that treatment is given to a person who is seen as already in trouble. Could be in minor trouble, could be in big trouble, but they're seen as in trouble by themselves, usually, and by providers and by fellow citizens. Whereas a person qualified for preventive step, is not seen as in trouble. They're only under a low risk generally. Now, should that make any difference if the negative results of not doing preventive measures are at least as great as the negative results of not providing treatment? That's then the question. In the case of children, I'm not sure we've settled that big issue about prevention-treatment relationship. We've just noted that when prevention can be particularly effective and when it's particularly inexpensive, do it. It's very important to include it first and foremost in basic care that you mandate people buy insurance for. Now, the matter of setting limits for basic care. Mandates make setting limits on basic care all the more important. Requiring people to purchase insurance makes it particularly important that the care covered by that insurance be effective, efficient, and worth its expense. Take, for example, arthroscopic surgery for arthritic knees, not for meniscal tears in these, but for arthritic knees. Major studies, 3 of them now, showing that that's not effective. It's a $4 billion aggregate procedure in U.S. orthopedics. The politics of this are really interesting. And if you think the recommendations that came out from certain bodies that this was not effective treatment get accepted by professional organizations like orthopedists, read the history of what happened in the last 10 years on that particular controversy. Sometimes even physicians don't pay attention, don't want to pay attention to scientifically credible studies. Other speakers have made this point. If you're going to require people to buy insurance, if that's the form the universal access to care takes, because of the argument that I've made, short of an argument for single-payer insurance, or whether it's even an argument for single-payer insurance where you're requiring people to pay as citizen taxpayers, isn't it unfair to require them to pay to contribute to insurance for ineffective care? It's exploitation. Let's be honest about this. It is the providers and the patients and the other people who are either wanting the care or selling the care, exploiting the insurance buyers and the taxpayers. That's what it is. It must be eliminated from basic care. And once people are under a mandate, or once they're in a single-payer system where they have to pay taxes to support the system, either one, you get much increased social consciousness about that exploitation, that unfairness of ineffective care being covered. That's why every other society that has universal access does have procedures for deciding what care gets not paid for, not covered, because it's not effective or not effective enough. And we'll be there too if we have a mandate and it sticks. Now, what is care that is sufficiently effective and cost-worthy? One proposal is it's care for which people would choose to insure when knowledgeable and imaginative. Ronald Dworkin has called this the Prudent Insurer model. This gets pretty hairy, so you may want to take a little nap for 5 minutes here. But we have to wrestle with the basic care. What's the basic minimum? And this is one proposal. And it's driven by something that does need to be acknowledged. I guess I don't want you to take a nap for this point. The insurance effect. A number of other speakers have sort of alluded obliquely to this, but we absolutely must face this. Health economists have noted it from the get-go about insurance. Insurance distorts incentives, hugely distorts incentives. It destroys the capacity of patients, who are the ones wanting care under the immediate need, under all sorts of stresses, and providers who are trained to provide the care and get their life's meaning out of providing care. Let's dignify it with something good. It's not just making money, although it might be that too. They get their life meaning out of providing care. When the patient is insured, the provider doesn't have to worry about the patient's ability to pay, and the patient doesn't have to either. And they will just lose all reference points about what is sufficiently valuable to justify the expense. They just do. You can't avoid that in an insurance situation. Now, we can get rid of insurance. David Goldhill in the Atlantic Monthly a couple years ago proposed we just reduce insurance a lot, and he has other fallback mechanisms for handling it. But that's one proposal. But if we're going to keep robust insurance, then we have to have somebody other than patients and providers making the decision about what care is worth enough in value, given the expense, that it should be covered by insurance. Now, who should that be? Well, since the source of the problem, the argument goes, is insurance itself, let's make people, before they get insured, the arbiters of this. What do they want to be insured for? But of course, who is it? This is going to have to be collective. If it's a mandated basic minimum, it's going to have to be some collective group because it's a mandate for the whole society. Single-payer systems, obviously, it's taxpayer. Now, in applying the prudent insurance model, to achieve fairness between likely well and likely ill, choice of insurance coverage for basic care cannot be left entirely to individual choice. We've crossed that already. I mean, the likely ill will want to put a lot of things in, and the likely well won't want to put much in at all. So it has to be some more neutral body. Some collective sense of basic minimum is required. Basic care is, this may not gain us much, but it's a way of sort of functional definition, is care that a society may use, is morally justified in using its coercive power, it is coercive power, to make universally accessible and garner the collective resources, in part, to fund. Now, with that, our conceptual background, what's a fair process for setting limits? This is Daniels and Saban's proposal. Decisions on coverage and limits, including those made after a member subscribes to a plan, must be publicly accessible. They're not all publicly accessible in private insurance company decisions. Rationale for such decisions must be reasonable in regard to value for money. Decisions must be marked by accountability for reasonableness. They don't say what the reasonable is. It's just that you have to be accountable to explain to people in your subscriber group or to society, if it's a wider group, why it's reasonable to set the limits the way you're setting them. And finally, there must be a fair process for challenging an appeal. Now, one of the things that somebody called me about a couple months ago, Dan Callahan, in fact, said, I understand out in Washington State you have an interesting program called the Health Technology Assessment Program. And why hasn't it been hit with all sorts of criticisms as Washington's rationing of health care, Washington State's rationing of health care? I said, well, I know we have it, and I know it does some good work. I don't know why it hasn't been hit with all these charges that hit all the other rationing, perceived procedures and things that are perceived as rationing. Well, we have a collective process. It is needed to decide the limits on basic care that is funded by Washington State taxpayers, Washington State employees, Medicaid, and a few other small things, basically Medicaid and state employees. There's now a commission. It's called, actually, the Health Technology Clinical Committee. Very wisely, the legislature, back in 2003, this is a very interesting political story of how this happened, said, on the basis of an experience in Oregon, not the big Oregon plan that you've heard about, but other experience in Oregon, much more immediate at the time, which Washington was participating in obliquely. A lot of people don't know that. Legislators, Republican and Democrat alike, said we have to have such a technology assessment committee here because there's a lot of wasteful stuff being done in medicine. Okay? The legislators said, well, we got to be really cautious. This is going to be a lightning rod politically. We're going to make this committee solely practicing health professionals. That'll make it a little more protected from political assault. So they did that. It's made 21 coverage decisions since 2007. 10 have been mostly positive, that is, most of the cares included. 11 have been largely negative, but all have carried detailed qualifications, well, some qualifications. That is, they've said, this care that we're excluding is still to be included for this small set of conditions, or the reverse case. In other words, it's been really sophisticated in its work. Take, for example, the recent decision about glucose monitoring for insulin-dependent children under 19. How many in this room are reasonably familiar with this case before the clinical committee? Oh, not many. Okay, I thought this might be old news to you. It was based on an evidence report that an outside vendor compiling evidence for the committee did that was 299 pages long and up on the web. Everybody could see what the evidence report was. That is all the evidence, all the studies that have been done on glucose monitoring for insulin-dependent children under 19. The prospective recommendation that it made was reported 2 months in advance for comment. A number of charges were made that this was very unfair because among the 11 people on the clinical effectiveness committee were not any endocrinologists. And that they shouldn't have even taken up the question to begin with, and they wouldn't have if there had been an endocrinologist on the committee. The committee defended itself, I think, very well in responding to this comment at the end of 2 months, and its final decision then was to cover self-monitoring of blood glucose, that is test strips, and without good evidence about optimal frequency, they put no quantity limits on that whatsoever. So totally in. But for continuous glucose monitoring devices not covered, they would not be covered except for those with severe hypoglycemia and who were enrolled in trials, because the evidence was so weak that it was effective, if present at all. Now, is that a fair process for deciding on whether something like continuous glucose monitoring gets in the basic care that the society supports either by a mandate to have insurance or by taxpayer funds? Well, you can complain that there weren't any patients and subscribers on this committee, and citizens on this committee. There were only 11 practitioners. But that was what the legislature thought would be insulate the committee. That membership was, in fact, the most politically insulate, the best political caution at the time. And they were probably right. So maybe we could do better, but it's a model for the society. My conclusion. For moderate, and I am a liberal myself, so I don't disparage liberal single-player plans at all, but I'll still describe a multiplayer payer plan as moderate. For moderate multiplayer versions of universal access, liberals and conservatives should be in great agreement. Children's right of universal access to basic care is as strong and in some respects stronger than a general right. In one respect, it may appear weaker, children are healthier, but it is not in fact weaker for that reason, because of effectiveness and relatively low expense. That, however, sets a precedent for a broader right of universal access to basic care, namely effectiveness and expense are relative to that, those limits there too. The scope of basic care must keep the mandatory context in mind, where you've either mandated insurance or you're forcing people to pay by taxing for a single-payer system. Thank you.
Thank you. We will now take a 15-minute break, and we will see you back at 3:30 when we'll start off with the panel of our last two speakers, and then we'll be concluding with the panel of the parents talking about this from their perspective. Thank you.